Okay, we will talk about osteoarthritis. We will begin our study with a case. You have a 60-year-old woman presented to you with 1-year history of pain in her left knee. She said that her pain increased towards the end of the day. Recently, her pain had become more severe and was associated with a crepitus and a stiffness of less than 15 minutes duration. On examination, we have an obese woman. On examination of the left knee joint, there was tenderness and swelling, a crepitus was palpable, and weakness of the left quadriceps muscle. What is the most likely diagnosis and how we manage this patient? Okay, so what is osteoarthritis? Osteoarthritis is a degenerative joint disease that is characterized by degeneration of the articular cartilage. The main organ to be affected in osteoarthritis is the articular cartilage. And in comparison to rheumatoid arthritis, the main organ was the synovium. In rheumatoid arthritis, the process starts in the synovium of the joint, whereas in osteoarthritis, it starts at the articular cartilage. Osteoarthritis is sometimes called degenerative joint disease. This name is actually better than osteoarthritis because there is little inflammation, if any, in this condition. So the term osteoarthritis is actually a misnomer. But we were going to use it here to avoid confusion. Osteoarthritis is the most common form of arthritis. It is more common in females, except at the hip joint, where the condition is equally seen in both genders. The condition is more common in obese because obesity is a major risk factor for osteoarthritis. How osteoarthritis is classified? Osteoarthritis is sometimes classified as either primary or secondary. In a primary, there is no obvious cause, sometimes regarded as an aging process. But actually it is not an aging process because an aging cartilage is different from an osteoarthritic cartilage. The secondary form occurs due to trauma, due to other diseases that affect the joints. Usually the secondary form is seen at an earlier age than the primary form. The prevalence of the primary form increases dramatically with age. Another classification is to be either classified as localized osteoarthritis, in which usually a single joint is affected, usually a large one, the hip or the knee joint. The second type is the generalized nodal osteoarthritis, in which multiple joints are affected, including both large and small joints. But specifically, it attacks the hands. It is characterized by formation of nodes, which we are going to talk about them later. This condition is highly more common in females and highly genetically transmitted. The genetic factors are implied in the localized nodal form more than in the generalized nodal form more than in the localized form. Now, let's come to the pathophysiology and pathogenesis of this condition. So normally there is a balance between cartilage synthesis and cartilage degeneration. This is the basis of cartilage remodeling. In osteoarthritis, however, there is an increase in the degenerative factors to the point where they overwhelm the synthetic factors, and so the cartilage is degraded more than synthesized. The degenerative factors are a group of enzymes called matrix metalloproteinases, MMPs. Those are the most important factors in this osteoarthritis condition, the matrix metalloproteinases. The triggering factors for increased production of MMPs is not fully understood, but an important factor that is highly suggested is the interleukin 1. Interleukin 1 is a pro-inflammatory factor that it's seen in high concentration in the synovial fluid of osteoarthritic joints. Okay, so what will happen is that the MMPs, the matrix metalloproteinases, are going to destroy the aggregans and the collagens that are found in the articular cartilage. These proteins, the aggregans and the collagens, form the ground substance of the articular cartilage. They are going to be destroyed by the MMPs. This will result at an early stage with fibrillation and the cracking of the cartilage. But as the condition progresses, there will be erosions that lead to bone exposure. So at the joint we have the cartilage above the bones. When the cartilages are eroded, the bones will be exposed. When the bones are exposed, they usually react. But how they will react? They will react by formation of a new bone. This bone will be aggregated as osteophytes or as subchondral bone sclerosis, in which there is increased bone deposition at the area immediately below the eroded cartilages. Okay, so these osteophytes are the source of pain and limitation of motion in case of osteoarthritis. Also, as a result of bone exposure, the synovial fluid will leak from the joint space into the subchondral bone, resulting in the formation of some subchondral bone cysts. So this is the pathogenesis of osteoarthritis. Interleukin-1 is possibly the main triggering factor. It will trigger an increase in the production of metalloproteinases to the point where they will overwhelm the growth factors. This will result in increased degradation of the cartilage by destruction of the aggregans and collagens in the articular cartilage. This will lead to fibrillation and cracking, and then erosions of the cartilage that end in bone exposure, which will react by formation of osteophytes and subchondral bone sclerosis and subchondral bone cysts. Okay, the clinical features. The main clinical feature of osteoarthritis is pain. This is the usual presenting symptom in osteoarthritis. The type of pain in osteoarthritis is a mechanical type of pain, and this is another point where osteoarthritis differs from rheumatoid arthritis, where the pain was an inflammatory type of pain. So in osteoarthritis we have mechanical type of pain, in which the pain increases with movement and activity and is relieved by rest, and the pain is associated with brief stiffness of less than 15 minutes. You can notice that this is completely opposite to what was seen in rheumatoid arthritis, in which the pain was increased by rest and relieved by motion and was associated with prolonged periods of stiffness. Okay, so the osteophytes will also lead to decrease in the range of motion. So we have pain, we have decreased range of motion. This will result in muscle wasting because of the disuse of the muscle. They will waste with time, and this is highly seen at the quadriceps in case of knee osteoarthritis. Also, on examination, there will be swelling of the joint and there will be tenderness, usually joint line or periarticular tenderness. And there is also a very characteristic feature of osteoarthritis is the crepitus. This crepitus result of when the destructed joint structures move, they will crackle. This will result in a palpable and audible sound, which is called a crepitus. This is highly significant for osteoarthritis. Okay, now I would like to talk about hand osteoarthritis. Hand osteoarthritis is important because we need to differentiate it from rheumatoid arthritis in the hand. In case of osteoarthritis, the hand is affected mainly at the distal interphalangeal joints, where we will see Heberden nodes. What are these nodes? Heberden and Bouchard nodes. These are actually aggregated osteophytes. When osteophytes form at the small joints, they will aggregate and form nodes which are highly characteristic of osteoarthritis. We have the Heberden's node at the distal interphalangeal joint, and we have the Bouchard nodes at the proximal interphalangeal joints. Also, the first carpo-metacarpal joint is affected in osteoarthritis, resulting in a squaring deformity of this joint. This results from subluxation at this joint. So in osteoarthritis, the main joints affected in the hand are the distal interphalangeal joints, the first carpo-metacarpal joint, and the proximal interphalangeal joints. Note that the metacarpophalangeal joints are not affected in osteoarthritis, and this is another point where it differs from rheumatoid arthritis, in which the MCP or the metacarpophalangeal joints are affected. Okay, so this is a picture of the main hand deformities seen in osteoarthritis. Here we can see the nodes at the proximal interphalangeal joints, the Bouchard's nodes, and at the distal interphalangeal joints, the Heberden's node. And we can also see the squaring deformity of the thumb due to subluxation of the first CM joint. Okay. Mainly all investigations in case of osteoarthritis are normal. All lab investigations are normal. The radiological findings are rarely seen at an early stage. But later on, the X-ray will become very useful in osteoarthritis, especially if we are planning for surgery. The main findings are there will be narrowing of the joint space, another point of difference between osteoarthritis and rheumatoid arthritis. In osteoarthritis, the narrowing of joint space is usually asymmetrical. One side of the joint is affected more than the other side, and this is not the case in rheumatoid arthritis, where the joint is usually narrowed symmetrically. Also, as we said, there will be subchondral bone sclerosis, seen as an increased density at the area below the cartilage, and there will be osteophytes formation and subchondral bone cyst. These features, which we have discussed in pathogenesis, are all seen on X-rays in case of advanced osteoarthritis. Okay, this is a picture at the knee joint. We can see here that there is more narrowing at the medial side of the joint than at the lateral side. This is not seen in rheumatoid arthritis, in which the narrowing is symmetrical on both sides. We can see these bone spurs that arise from the femur. These are the osteophytes. We can see increased density. I'm not sure if it is obvious, but there is increased density at the area just below the cartilage. This is the subchondral bone sclerosis. This is a picture of the hip joint, where we see clearly the subchondral bone sclerosis, increased density just at the sides of the joint. We can see a cyst. There is a small cyst just above the head of the femur, and there is also loss of joint space, which is asymmetrical. Okay, now let's talk about the lines of management. How to manage a patient with osteoarthritis. Osteoarthritis is actually a lifelong process. There is no drug that can reverse the osteoarthritis process. We can slow the process, we may be able to stop it, but we cannot reverse it. We have to tell our patients this. But there are actually many things that can be done to slow the process. We should tell our patients to decrease weight. This is very important. Obesity implies a great deal of stress on the joint, especially if we are talking about the knee joint or the hip joint. So decreasing weight will decrease the force applied over the joint. Also, smoking should be stopped. And also very important are the exercises. Both aerobic exercises, those exercises that increase the activity of the heart and blood supply to the joint, and the strengthening exercises are very important to avoid muscle wasting. Okay, so lines of management. The drug of choice for osteoarthritis is the acetaminophen. Acetaminophen is the main pain drug for osteoarthritis. It is better than NSAIDs. It has the same efficacy as the NSAIDs, but it has no side effects, so it is better tolerated than NSAIDs. So the first step is to give the patient acetaminophen or paracetamol. Second line is the intra-articular steroid injection. If the patient cannot tolerate the pain or with acetaminophen, we can try intra-articular steroid injection. And when the patient reaches this step of intra-articular steroid injection, especially if it is repeated many times, we should consider surgery. We should plan for surgery such as joint replacement. And this all what you need to know about osteoarthritis. Thank you.